All right, let's dive right in. We're about to simulate a consultant-level surgical oral exam focusing on anorectal emergencies. To make this feel as real as possible, I'm going to play both roles, the tough examiner and the sharp candidate. Let's see how this unfolds. So, here's our game plan. We're going to tackle this just like you would in a real exam, following the logical flow of a clinical case. We'll start with the scenario, then dig into the history and exam, build our differential diagnosis, and finally talk about management and all the nasty stuff you can't afford to miss. This kind of systematic thinking is exactly what they're looking for. Let's get started. Okay, examiner hat on. Right, let's begin. You've been called to the emergency department to see a 45-year-old man. He's a known diabetic, and for the last 48 hours, he's had really bad perianal pain and a fever. Tell me, how do you proceed? And now as the candidate. Okay, thank you. Well, my first priority is safety. I'd start with a quick ABCDE assessment to make sure he's stable. Then I'd move straight into a focused history and a systematic physical exam to start figuring out what's going on.
Good start. So tell me, what specific things are you going to ask about in the history?
Right. The really crucial details are, number one, the pain. I need to know exactly what it feels like. A constant, throbbing pain that doesn't really change when he goes to the bathroom, that screams abscess. Number two, I'm confirming the systemic stuff, the fever, the chills. That tells me we're dealing with a real infection. Three, I'm digging into his past medical history. We already know he's diabetic, but how good is his control? Has he ever been diagnosed with something like Crohn's disease, or is he immunocompromised for any other reason? That all changes the game. And finally, I'd ask about any swelling, and then I'd specifically try to rule out other things, like that classic sharp tearing pain you get with a fissure, or if he's seen any blood.
Okay, the history is pointing you in one direction. What are you expecting to find when you examine him?
So, after making sure he's comfortable and has some privacy, I'd start with inspection. I'm looking for any redness, cellulitis, or a visible swollen lump near the anal verge. Then, on palpation, I'm gently feeling for tenderness and, this is the key, fluctuance, that sort of boggy, fluid-filled feeling that tells you there's pus under there. After that, I'd attempt a gentle digital rectal exam. Now, this is interesting because if there's not much to see on the outside, but he's in agony when I do the DRE, I'd be very suspicious of a deeper abscess. But here's the absolute critical point of caution. If he's in too much pain, I'm not going to force it. That tells me we need to go straight for an examination under anesthesia, or EUA, where we can diagnose and treat him at the same time.
All right, so with all that information from the history and the exam, the logical next step is to put it all together and come up with a clear differential diagnosis.
Excellent. So lay it out for me. What are your top 3 differential diagnoses for this patient? Okay, my top 3 would be, number 1, far and away is an anorectal abscess. The constant throbbing pain, the fever, and his diabetes just fit that picture perfectly. Number 2, I'd consider an acutely thrombosed external hemorrhoid. That usually comes on very suddenly with a super painful bluish lump right at the edge of the anus. And number 3 would be an anal fissure, but that's less likely because the pain is usually sharp and tied directly to having a bowel movement. Honestly, all signs are pointing to the abscess.
And to really understand what's happening and plan the surgery, it's so important to have the anatomy clear in your head. As you can see here, these infections usually start in a tiny blocked gland between the sphincter muscles. From there, the pus can track into a few different spots: the perianal space, the deeper ischiorectal fossa, or even way up high, creating a supralevator abscess. Knowing these pathways is absolutely key to making sure you drain it properly and it doesn't come back.
Exactly right. Your examination under anesthesia confirms it. A tender, fluctuant mass in the ischiorectal fossa, just like we see in this diagram. Before we talk treatment, just for completeness, what blood test would you have ordered? I'd get a full blood count, UNEs, a CRP to check for inflammation, and a blood sugar. If he seemed really sick, I'd take blood cultures too. And while this is a clinical diagnosis, in a really complex or recurrent case, a CT or MRI could be helpful to map out just how far the abscess has spread. Good. Now let's move on to treatment.
Okay, diagnosis is locked in. Now we pivot to the most important part. What are we going to do about it? Time to talk surgery. So, what is the definitive treatment for an anorectal abscess?
Surgical drainage.
The one and only principle is prompt incision and drainage. Waiting is not an option. It just lets the infection spread. And antibiotics alone will not fix this. They're really only for patients with a lot of surrounding cellulitis, signs of sepsis, or high-risk patients like this one. For a simple abscess, you make an incision over the spot that feels most fluctuant, and you make it close to the anal verge.
That's really important because it minimizes the length of any fistula that might form later. For more complex things like a horseshoe abscess, you need separate incisions and a drain. Post-op care is all about sitz baths, pain relief, and stool softeners. And you have to follow these patients up because about half of them will develop a fistula down the line that needs another operation. Of course, a good Viva will always test the breadth of your knowledge. They don't just stick to the initial case. They want to see what else you know.
Excellent. Let's switch gears. A patient has a chronic amyl fissure that just won't heal with creams. Describe the gold standard surgical procedure for me.
The gold standard is a lateral internal sphincterotomy, or LIS. The healing rates are fantastic, over 90%. The whole idea is to make a controlled cut in the internal sphincter muscle to relieve the spasm that's preventing the fissure from healing. Now, the most important part of consenting a patient for this is talking about the small but real risk of some degree of incontinence afterwards. Post-op care is pretty straightforward. Sitz baths, pain relief, and fiber. We'd see them back in clinic in about 6 weeks to make sure everything's healed up.
Very good. Now for hemorrhoids. Briefly compare the two main ways to surgically cut them out.
Sure. So the two main techniques are the Ferguson, which is the closed one, and the Milligan-Morgan, the open one. With the Ferguson, you stitch the wound closed. This might mean a bit less pain right after surgery and maybe faster healing initially. With the Milligan-Morgan, you leave the wound open to heal on its own. It takes longer, but some believe it lowers the risk of infection. Pain is a big deal with both, so that has to be managed well. But the most important thing to tell a patient, and for an exam, is that long-term, the results are basically the same for both.
And finally, we get to what might be the most important part of any surgical exam: knowing the complications and recognizing the red flags you absolutely cannot afford to miss.
Last question. What is the one life-threatening diagnosis you must not miss in a patient with severe anorectal pain, especially someone like our diabetic patient from the beginning? The diagnosis you cannot miss is a necrotizing perineal infection, like Fournier's gangrene. The classic sign and the thing everyone needs to remember is this. The patient has severe, agonizing pain that is completely out of proportion to what you see on exam. The skin might just look a little bit red, but the patient is climbing the walls in pain and looks sick. The risk factors, diabetes, kidney failure, obesity, are huge red flags. Missing this is an absolute disaster. It's a surgical emergency. They need fluids, heavy-duty antibiotics, and immediate aggressive surgery to cut away all the dead tissue. So the take-home message is simple. In a high-risk patient with pain that just doesn't match the physical findings, you have to have an incredibly high suspicion for a necrotizing infection.